Brand new research published just 3 weeks ago is forcing the medical community to confront a truth that many doctors were never trained to question. For decades, we have repeated the same sentence to patients, medical students, and even to ourselves. The ideal blood pressure is 120/80. Lower is better. Closer to that number is safer. That belief has been treated almost like a law of nature. But science does not work on beliefs. It works on evidence. And the evidence is now showing something deeply uncomfortable. For older adults, especially those over 65, and even more so over 75, aiming aggressively for 120/80 may not protect life. It may shorten it. I am Dr. Sandra Miller, and after more than 2 decades working as a cardiac surgeon and treating elderly patients at every stage of cardiovascular disease, I can tell you this with absolute certainty. Blood pressure targets must change with age. What protects a 45-year-old can seriously harm a 78-year-old. And the failure to recognize this difference has already cost many lives. For years, the medical system has pushed a one-size-fits-all number, ignoring the profound physiological changes that occur as we age. New data published in the Journal of the American Medical Association shows that in seniors, particularly those over 75, overly aggressive blood pressure lowering is associated with higher rates of falls, fractures, kidney injury, cognitive decline, and death. Yet most patients are never told this. Doctors still chase 120/80 because that is what guidelines once said, and because guidelines change slowly. But bodies do not follow guidelines. They follow biology. And aging biology follows a completely different set of rules. Before I tell you the blood pressure range that is actually safer for older adults, you need to understand why the traditional target can become dangerous with age. Because if I simply give you a number without the explanation, you might misunderstand it, or worse, try to apply it blindly, without context. And context is everything. Let me explain what happens inside the body of an older adult when blood pressure is pushed too low. As we age, our arteries gradually lose elasticity. This process, called arterial stiffening, means blood vessels no longer expand and recoil the way they did when we were younger. In a younger person, flexible arteries help buffer changes in pressure when standing, walking, or changing posture. In an older adult, stiff arteries cannot compensate as quickly. This means that maintaining adequate blood flow to the brain requires slightly higher pressure, not lower. When pressure drops too far, especially during position changes, blood simply does not reach the brain fast enough. That is when dizziness begins. That is when balance becomes unstable. And that is when falls happen. There is also a second critical factor, baroreceptor sensitivity. Baroreceptors are pressure sensors located in the neck and chest that tell the brain how to adjust heart rate and vessel tone. In younger adults, they respond instantly. In older adults, they respond slowly. Sometimes too slowly. So when an older person stands up, their blood pressure can drop sharply before the body has time to correct it. If their baseline pressure is already low, this drop becomes dangerous. This condition is called orthostatic hypotension, and it is one of the most underdiagnosed and underestimated causes of falls and fractures in seniors. And this brings me to Eleanor. Eleanor was 78 years old when I first reviewed her case. She had been diagnosed with high blood pressure a decade earlier. At the time of diagnosis, her pressure was 152/88. That number is elevated, but not extreme for someone her age. Still, her doctor followed standard protocol and started medication. Her pressure came down gradually. 138/82, then 128/76. Each time, the doctor was pleased, but insisted it still was not ideal. The goal remained 120/80, so the dose was increased. Then another medication was added. Eventually, Eleanor reached 122/78. Her doctor celebrated. He told her this was perfect. He told her she was safer than ever. But Eleanor did not feel safer. She began to feel dizzy when standing. At first, just for a moment. A brief spinning sensation. Then it became more frequent. Every time she stood up, she had to grab something. She mentioned this to her doctor. He reassured her, said it was age-related. told her to stand up slowly. This is one of the most dangerous reassurances in medicine, because dizziness on standing is not just age. It is often a warning sign that the brain is not receiving enough blood. 3 months later, Eleanor stood up from bed in the early morning. Her blood pressure collapsed. She lost consciousness.
She fell.
She fractured her hip. At the hospital, paramedics measured her blood pressure lying down, sitting, and standing. Lying down, it was 118/74. Standing, it dropped to 82/54. That is catastrophic orthostatic hypotension. Her brain was being deprived of blood every time she stood. The fracture led to surgery. The surgery led to immobility. The immobility led to pneumonia. And 6 months later, Eleanor was dead. Not from a heart attack. Not from a stroke. But from a fall triggered by blood pressure that was too low for her age. This is not a rare story. It is a pattern. And it raises a terrifying question. How can a perfect blood pressure number kill someone? The answer is simple. Because 120/80 is not perfect for seniors. Blood pressure targets were originally established using data from middle-aged adults, people in their 40s and 50s, flexible arteries,
Fast reflexes,
robust kidney function. None of these apply to the average 80-year-old. Older adults process medications differently. Kidney clearance is reduced. Liver metabolism slows. Drugs last longer in the bloodstream. A dose that is reasonable for a 55-year-old can be excessive for an 80-year-old. And when blood pressure drops too far, the risks become immediate, not theoretical. A stroke from moderately elevated blood pressure may take years to develop. A fall from low blood pressure can kill an elderly person in weeks. This is why geriatric medicine focuses on function, not numbers. Independence, balance, mobility, cognitive clarity. These matter more than hitting an arbitrary target. New large-scale studies now confirm what experienced clinicians have observed for years. In adults over 75, the lowest mortality is not seen at 120 systolic. It is seen between 130 and 140. Below 120, mortality increases. Above 150, risk increases again. There is a middle zone where the brain is perfused, kidneys are protected, falls are reduced, and quality of life is preserved. But that number is not the same for everyone. And that is what we will explore next. Now that you understand why blindly chasing 120/80 can be dangerous for older adults, we need to address the most important concept in senior cardiovascular care. There is no single right blood pressure number for everyone after 65. The correct target depends on who you are, how old you are, how resilient your body is, and what other medical conditions you carry with you. This is where medicine often fails seniors. Too many decisions are made based on charts and guidelines rather than on physiology and real-world outcomes. And the truth is this. Two people of the same age can require completely different blood pressure targets to stay safe. Let me explain why. As we age, several systems change simultaneously. Arteries stiffen. Reflexes slow. Kidney filtration decreases. Muscle mass declines. Balance becomes more fragile. The brain becomes more sensitive to fluctuations in blood flow. All of this means that the margin for error becomes much smaller. In a younger adult, blood pressure can fluctuate without consequence. In an older adult, a drop of 20 or 30 points can mean dizziness, confusion, or a fall. This is why we must individualize blood pressure goals. Let me give you a clear framework based on the latest research and decades of clinical observation. For adults between 65 and 75 years old who are generally healthy, active, and not frail, a systolic blood pressure in the range of 130 to 140 is usually safer than pushing aggressively toward 120. This range maintains good blood flow to the brain while still offering cardiovascular protection. Some very healthy individuals in their late 60s may tolerate systolic pressures closer to 125 or 130, but only if they have no dizziness, no weakness, no cognitive fog, and no orthostatic hypotension. The moment symptoms appear, that target becomes unsafe. For adults between 75 and 85, even if they are relatively healthy, the balance shifts further. Arterial stiffness is more pronounced. Baroreceptor response is slower. Muscle strength and balance are reduced. In this group, research consistently shows the lowest mortality and best quality of life with systolic pressures between 135 and 145. This range is not arbitrary. It reflects the pressure needed to maintain cerebral perfusion while minimizing fall risk. Lower than this, and the risk of syncope and fractures rises sharply. For adults over 85, or for anyone who is frail regardless of age, the priority is not preventing a heart attack 10 years from now. The priority is preventing a fall next week. In this group, systolic pressures between 140 and 150 are often the safest option. Yes, that number may sound high compared to what you've been told your entire life. But in this context, higher does not mean dangerous. It means protective. Now let me make something very clear. This does not mean high blood pressure should be ignored. Pressures consistently above 160 or 170 do increase the risk of stroke and heart failure. But the difference between 135 and 145 in an 82-year-old is not the same as the difference between those numbers in a 45-year-old. Age changes the equation. This is why the newest large observational studies have been so important. When researchers finally looked specifically at adults over 75, including those with diabetes, kidney disease, prior strokes, and frailty, they found that the lowest death rates were not in those with the lowest pressures. They were in those with moderate pressures. Those with systolic pressures below 120 had higher mortality, not lower. They experienced more falls, more kidney injury, more hospitalizations, and more cognitive decline. This finding shocked many clinicians because it contradicted what they had been taught. But when you understand aging physiology, it makes perfect sense. Now, let's talk about another critical factor, diastolic pressure, the bottom number. In older adults, systolic pressure tends to rise while diastolic pressure often stays the same or even falls. This creates what we call a widened pulse pressure. For example, 150 over 70. That difference is normal with age. What is dangerous is when diastolic pressure drops too low. Diastolic pressure is what feeds the heart muscle itself during relaxation. If diastolic pressure falls below about 60, blood flow to the heart and brain can be compromised. This can cause chest discomfort, fatigue, cognitive fog, and increase the risk of falls. So while we often focus on systolic targets, diastolic pressure must be protected, ideally staying between 65 and 85 in most seniors. Now let me explain why symptoms matter more than numbers. Many older adults are told their blood pressure is perfect because it looks good on paper. But they feel terrible. Dizziness, weakness, trouble concentrating, fatigue, fear of standing up. These are not signs of aging. These are signs of underperfusion. If you feel worse after your blood pressure medications were increased, that is not something to ignore. It is information. Your body is telling you that the pressure may be too low for you. This is why we must always check for orthostatic hypotension. Orthostatic hypotension means your blood pressure drops significantly when you stand up. It is one of the strongest predictors of falls in seniors. And yet, it is rarely checked. Here is how it works. When you stand, gravity pulls blood toward your legs. Your body should respond instantly by tightening blood vessels and increasing heart rate. In older adults, that response is delayed. If baseline pressure is low, the drop becomes dangerous. A drop of 20 points systolic or 10 points diastolic when standing is considered abnormal. And if that drop is accompanied by dizziness, lightheadedness, or blurred vision, it is a red flag. Many tragedies could be prevented if this simple test were done routinely. Now let me give you another example, because real people make this clearer than statistics. Harold was 72 years old. His blood pressure was 146 over 88. His doctor wanted it at 120 over 80. Medication was started. His pressure came down to 124 over 78. On paper, perfect. But Harold felt awful. He was exhausted, dizzy, mentally foggy. He stopped enjoying life. When his case was reviewed, it became clear that his original pressure was not dangerous for someone like him. He was active, had no diabetes, no kidney disease, no heart disease. We reduced his medications. His pressure stabilized around 136/82. His symptoms disappeared. His energy returned. That pressure was safe for him. Now compare that to Margaret, also 72. Same age, completely different situation. She had diabetes, prior heart disease, and kidney impairment. For her, 146/88 carried real risk. But pushing her to 120 would have been too aggressive. Her optimal range turned out to be around 130/80. Not 120. Not 145. Individualized. Same age. Different targets. This is the core message. Blood pressure management after 65 must be personalized. Guidelines are tools. They are not laws. And they must never override physiology or common sense. Now we need to talk about the most dangerous warning sign in older adults with blood pressure treatment. A sign that is frequently ignored, rarely tested, and tragically misunderstood. This single issue is responsible for thousands of falls, fractures, hospitalizations, and deaths every year. And yet most seniors have never been tested for it. I'm talking about orthostatic hypotension. If you remember only one thing from this video, let it be this. Your blood pressure while lying down means very little if it drops dangerously when you stand up. This is where the real danger lies. Orthostatic hypotension happens when your blood pressure falls significantly as you move from lying or sitting to standing. Gravity pulls blood toward your legs. In a healthy, younger body, sensors in your arteries immediately detect this shift and correct it. Your heart rate increases. Your blood vessels constrict. Blood flow to the brain is preserved. But in older adults, that system is slower and weaker. Arteries are stiffer. Baroreceptors are less sensitive. Muscles in the legs are weaker and less able to help pump blood upward. The result is that when an older adult stands, blood pressure can drop suddenly and dramatically. And when that happens, the brain does not receive enough blood. The symptoms can be subtle at first. Lightheadedness. A brief dizzy spell. Feeling off for a few seconds. Needing to grab onto furniture. Many people brush this off and say, "That's just age." It is not. It is a warning sign. When blood pressure drops too much upon standing, the risk of falling increases exponentially. And for older adults, a fall is not a minor event. A fall can be life-altering or life-ending. Let me explain what qualifies as orthostatic hypotension. Clinically, we define it as a drop of at least 20 points in systolic pressure or 10 points in diastolic pressure within 3 minutes of standing. But numbers alone don't tell the full story. Even smaller drops can be dangerous if they cause symptoms. If your pressure is 135/80 lying down and drops to 110/68 when standing, that may technically meet criteria, but if you feel fine, it may be acceptable. However, if your pressure drops from 125/75 to 95/60 and you feel dizzy, weak, or confused, that is dangerous. Symptoms matter. Now here's the problem. Most blood pressure measurements are taken while seated in a doctor's office. Rarely lying down. Almost never standing. And almost never compared. So doctors think everything is fine. Patients are told their numbers are perfect. Meanwhile, at home, those same patients are feeling dizzy every time they stand. This disconnect is where tragedy happens. Let me take you back to Eleanor's story for a moment, because it illustrates this perfectly. Eleanor's blood pressure looked ideal while she was seated. But when she stood up, her pressure collapsed. That collapse was never detected until after she fell and broke her hip. By then, it was too late. Now here's the part that should make you angry. Orthostatic hypotension is incredibly easy to test. It requires no special equipment.
No imaging.
No lab work. Just a blood pressure cuff and 5 minutes of time. Yet it is not routinely done. So I want to empower you to check this yourself at home and to bring the results to your doctor. Here's how to do it properly. First, lie down flat on a bed or couch. Relax completely. Rest for 5 full minutes.
Do not rush this step.
This allows your blood pressure to stabilize. After 5 minutes, measure your blood pressure while still lying down. Write the numbers down. Next, stand up carefully. Do not walk. Stand still. Within 1 minute of standing, Measure your blood pressure again. Write those numbers down. Then, after 3 minutes of standing, measure it one more time. Compare the numbers. If your systolic pressure drops by more than 20 points, or your diastolic drops by more than 10 points, you have orthostatic hypotension. If you experience dizziness, blurred vision, weakness, or confusion during this test, that is clinically significant even if the numeric drop is smaller. This information is critical. Because here's the truth. A blood pressure that looks good lying down can be dangerously low when standing. Now, let's talk about why orthostatic hypotension is so dangerous in older adults. When blood flow to the brain drops repeatedly, even briefly, the brain suffers. Over time, this can contribute to cognitive decline, slower reaction times, and impaired balance. Acute drops can cause loss of consciousness or falls. And falls are catastrophic after 65. A hip fracture alone carries a mortality rate of up to 30% within 1 year in older adults. Many who survive never regain their independence. They become fearful of movement. They decondition. Muscles weaken. Lungs weaken. Infections follow. What started as a perfect blood pressure number ends in loss of independence or death. This is why preventing falls must be prioritized over chasing aggressive blood pressure targets in seniors. Now let me address something very important. Orthostatic hypotension is often caused or worsened by medications. Blood pressure medications, especially when used in combination, can lower resting pressure to levels that the aging body cannot tolerate when upright. Diuretics reduce blood volume. Vasodilators prevent blood vessels from tightening. Beta blockers blunt heart rate response. In a younger body, these effects are manageable. In an older body, they can be devastating. This does not mean blood pressure medications are bad. It means they must be used carefully, thoughtfully, and adjusted based on real-world function, not just seated numbers. Now, let me give you another real-life example. Thomas was 74 years old. His blood pressure in the office was 128/76. His doctor was pleased. But Thomas complained of dizziness when standing. He was told it was unrelated. When we checked his orthostatic pressures, the truth became clear. Lying down, his pressure was 128/76. Standing, it dropped to 98/58. That is a 30-point systolic drop. This is severe orthostatic hypotension. We reduced one of his medications. His resting pressure rose to 136/80, but his standing pressure stabilized at 118/72. The dizziness disappeared. His fall risk dropped dramatically. On paper, his blood pressure looked worse. In reality, his health and safety improved. This is the difference between treating a number and treating a human being. Now, let's talk about another group at high risk. Older adults who feel fatigued, mentally foggy, or unusually weak. These symptoms are often blamed on aging, but they are frequently signs of low cerebral perfusion. The brain is not getting enough blood. Studies using advanced brain imaging have shown that older adults with very low blood pressure often have reduced blood flow to critical brain regions involved in memory, attention, and executive function. Some researchers now believe that overly aggressive blood pressure lowering in late life may contribute to cognitive decline. This is still being studied, but the concern is real. Again, moderation matters. Now here is the key takeaway of this entire block. If you are over 65 and experiencing dizziness, lightheadedness, weakness, confusion, or fear of standing, your blood pressure may be too low for your age, even if your doctor says it is perfect. Orthostatic hypotension must be ruled out. And if it is present, your treatment plan needs to change. If 120/80 is not ideal for everyone, then what should your blood pressure actually be as you age? And the answer may surprise you, because it's not one number. It never was. One of the biggest mistakes modern medicine has made is trying to apply a single blood pressure target to every adult, regardless of age, physical condition, or real-world function. The body at 45 is not the same body at 75. The cardiovascular system at 60 is not the same at 85. And pretending otherwise has cost lives. Let's talk about what the research actually shows. Over the past decade, several large observational studies and long-term follow-ups have examined mortality, fall risk, stroke risk, kidney injury, and cognitive decline in older adults at different blood pressure ranges. And the results are remarkably consistent. For most adults over 65, the lowest risk of death and disability does not occur at 120 systolic. It occurs higher.
Why?
Because older bodies need adequate pressure to push blood through stiffer arteries, up to the brain, and into vital organs. Let's break this down by age group, because this is where clarity matters. Adults ages 65 to 75, generally healthy if you are between 65 and 75 years old, active, living independently, and without major chronic conditions such as advanced kidney disease, prior stroke, or severe heart failure. The safest systolic range for most people is 130 to 140 millimeters of mercury. This range provides a balance. It is low enough to reduce long-term cardiovascular risk, but high enough to maintain brain perfusion, prevent dizziness, and reduce fall risk. Some very healthy individuals in this age group may tolerate systolic pressures closer to 125 or even 120. But tolerance is the key word. If lowering blood pressure to those levels causes dizziness, weakness, confusion, or orthostatic drops, then it is not safe, regardless of what guidelines say. Function always overrides theory. Adults ages 75 to 85. Changing physiology. Once you cross 75, important physiological changes accelerate. Arterial stiffness increases. Baroreceptor sensitivity declines further. Muscle mass decreases, reducing the calf muscle pump. Medication clearance slows. In this group, the safest systolic range for most people shifts slightly higher, 135 to 145 millimeters of mercury. This is the range associated with lowest mortality in several large real-world studies. Importantly, this range significantly reduces the risk of orthostatic hypotension, falls, and syncope, while still offering reasonable protection against stroke. Trying to force blood pressure down to 120 in this age group frequently results in harm. And this is where many clinicians struggle because they were trained under older paradigms. But medicine must evolve with evidence. Adults over 85 or frail at any age for adults over 85, or for anyone who is frail regardless of chronological age, priorities change completely. At this stage, preventing falls, preserving independence, and maintaining quality of life are more important than theoretical long-term cardiovascular risk. For these individuals, systolic blood pressure in the range of 140 to 150 millimeters of mercury is often the safest choice. Yes, that number may look high on paper, but in practice, it often keeps people upright, alert, mobile, and alive. Lowering blood pressure aggressively in frail seniors is one of the most common causes of preventable injury. A fall caused by low blood pressure can kill an 85-year-old far more quickly than moderate hypertension ever would. What about diastolic pressure? Now, let's address something that is often ignored. While systolic pressure gets most of the attention, diastolic pressure matters deeply in older adults. Diastolic pressure is what maintains blood flow to the heart muscle and brain during relaxation. In seniors, diastolic pressure that falls below 60 millimeters of mercury is associated with increased risk of heart ischemia, dizziness, and cognitive impairment. Ideally, diastolic pressure in older adults should remain above 65 and preferably between 70 and 85. Many seniors who are aggressively treated for systolic pressure end up with dangerously low diastolic values. This is not safe. Why the perfect number myth persists? You might be wondering why so many doctors still insist on 120 over 80. The answer is not bad intentions. It's outdated training. Most foundational blood pressure trials were conducted in middle-aged adults, not seniors. When older adults were included, frail individuals were often excluded. So the data simply doesn't apply cleanly to the real-world elderly population. Newer studies that include adults over 75, including those with frailty, diabetes, kidney disease, and prior strokes, consistently show a U-shaped risk curve. Too high is dangerous. Too low is dangerous. The safest point is in the middle. Now let me give you a powerful real-world example. William was 70 years old.
Healthy.
Active.
No diabetes.
No heart disease. His blood pressure hovered around 142/84. His doctor wanted to push it to 120. William felt great at 142.
No dizziness. No fatigue. No confusión.
We reviewed the evidence together. For someone like William, the benefit of lowering to 120 was minimal, while the risk of side effects was real. We left his pressure where it was. Years later, William remained active, independent, and complication-free. This is individualized care. Now contrast that with Margaret. Margaret was also 72, but she had diabetes, prior heart disease, and early kidney dysfunction. For her, 145/88 carried real risk. We targeted 130 to 135 systolic, not 120. She tolerated it well.
No dizziness.
No falls. Same age. Different body.
Different target.
This is why one number never fits all. The most important question you must ask, the most important question is not, what number should I aim for? The most important question is, at what blood pressure do I feel stable, clear-headed, and safe on my feet? Because blood pressure that looks ideal but makes you afraid to stand is not healthy. Blood pressure that causes dizziness is not protective. Blood pressure that steals independence is not success.